Welcome, fellow investigators. We've got a new case on our hands. The victim? Well, that's your patient. And the assailant? A mysterious, often debilitating primary headache. So I want you to forget your white coat for a moment. Today, you are a detective. Your clinic? That's your Baker Street. Your knowledge is your magnifying glass. And this explainer? Well, this is your casebook. The game, as they say, is afoot. Let's begin our investigation.
So, a patient walks in with this exact complaint. It's a classic opening scene, isn't it? The facts are sparse, the symptoms are dramatic, but a master detective knows that every mystery, no matter how perplexing, has a solution. Our first step is to really appreciate the sheer scale of this whole criminal enterprise. Think about this for a second. About 15% of the entire world's population is afflicted by migraine alone. This isn't some rare, exotic condition. It's one of the most common neurologic disorders out there. You are on the front lines and you're facing a very, very prolific offender. So, to catch this culprit, we've got to understand the scene of the crime. And our investigation, it takes us deep into the most complex territory you can imagine, the human brain. You know, every good detective starts by mapping out the area, right? Getting the lay of the land before they even start looking for clues. So let's examine the neurological pathways where this whole plot unfolds. Okay, so what you're looking at here is our crime scene map. The key pain signal, it kicks off in the trigeminal system, gets processed through what's called the trigeminal nucleus caudalis, or TNC, and then it travels up to the thalamus. That's kind of the brain's central relay station. Key structures like the hypothalamus are involved too, which helps explain some of those early pre-headache symptoms. And there's a key molecule of interest in this whole affair. Let's talk about CGRP. This little neuropeptide is a major player in this whole mystery. During a migraine attack, it gets released and it causes vasodilation, inflammation, and it transmits those pain signals. The best way to think of it is as the getaway car for pain, speeding it right through the nervous system. And as you can imagine, intercepting this vehicle has become a cornerstone of modern therapy. You know, the most critical piece of evidence in any headache case, it doesn't come from a lab test or some fancy imaging study. Nope, it comes directly from the patient. This is the interrogation phase. A meticulous history is your absolute best tool. By asking the right questions, you can uncover the culprit's signature pattern, its MO. And what a predictable pattern it is. A migraine attack usually follows 4 distinct phases. First, you've got the premonitory phase. This can be hours or even days before the pain hits. The patient might feel tired, get food cravings, or have mood changes. Then, for about 20% of patients, comes the aura. These are those classic neurologic symptoms, like a scintillating scotoma, the shimmering blind spots. Third is the main event, the headache phase itself, the throbbing pain, the nausea, the sensitivity. And finally, the postdrome. We call it the migraine hangover, where the patient just feels totally drained. Understanding this timeline is absolutely crucial. Now, no master criminal works alone. Migraine has its accomplices, the triggers. And these can be anything from bright lights and loud sounds to stress, hormonal shifts, or even just a glass of red wine. Identifying these accomplices is a key step for sure, but to truly solve the case, we have to profile the main culprits. So let's turn our attention to the usual suspects. In the world of primary headaches, you're going to encounter a few usual suspects. Each one has a very distinct profile, a unique signature that lets you tell them apart. Your job as a detective is to know these profiles inside and out, starting with the 2 most common offenders. Here we have our 2 most wanted, migraine and tension-type headache. Migraine is typically on one side. It's throbbing and it gets worse with activity. And crucially, it comes with baggage, nausea, vomiting, photophobia, phonophobia. Tension-type headache, on the other hand, is pretty much the opposite. It's usually on both sides, it's a dull, pressing, or tightening pain, and, this is the key, it lacks all those associated features. And right here, this is a crucial piece of deductive reasoning. Sometimes the most important clue is what isn't there. The great headache detectives have taught us that the absence of nausea, photophobia, and phonophobia strongly points you away from migraine and towards a tension-type diagnosis. It's a classic technique, but what about the more aggressive offenders? Now, we open the case files on a notorious gang, the trigeminal autonomic cephalalgias, or TACs. Just look at cluster headache, severe, one-sided pain around the eye, lasting anywhere from 15 to 180 minutes with autonomic features like tearing or a runny nose on that same side. Compare that to paroxysmal hemicrania, shorter, more frequent attacks that have a telltale clue. They respond dramatically to indomethacin. And then there's SUNC/SUNA, with even shorter stabbing attacks. The duration and frequency, those are your fingerprints here. Okay, so once you've identified your culprit, it's time to act. It's time to deploy your therapeutic arsenal. A good detective doesn't just solve the crime, they stop it from happening again. And this requires a 2-pronged strategy. So you have 2 main approaches. Abortive therapy, that's your SWAT team. You deploy it to stop an attack that's already in progress. Preventive therapy, on the other hand, that's your team of beat cops on patrol. Their job is to increase surveillance and prevent attacks from happening in the first place. We reserve that for patients with frequent or really disabling headaches. When an attack is in progress, a clear protocol is your best weapon. For a mild to moderate attack, you might start with simple NSAIDs. If that fails, or if it's a more severe attack, you escalate to the triptans. Next up, we have the newer CGRP antagonists. And for patients with a lot of nausea, dopamine receptor antagonists are an excellent choice because they treat both the pain and those associated symptoms. A master detective knows that you've got to choose the right tool for the specific situation. Let's look at some case-specific strategies. Say you have a patient who wakes up with a headache and is already vomiting. Well, an oral pill isn't going to do much good, right? This is a job for a sumatriptan nasal spray or an injection. What about a patient with really rapidly developing symptoms? An injectable might be your best bet there. Knowing your arsenal is half the battle. For long-term prevention, your toolkit expands quite a bit. We have established agents like beta blockers, certain antidepressants like amitriptyline, and anticonvulsants like topiramate, though just be mindful it can sometimes cause cognitive side effects. And of course, the new kids on the block, the monoclonal antibodies and small molecules that target CGRP. These have really truly changed the game for long-term surveillance and prevention. You know, a detective's work is never done. Beyond the usual suspects, you're going to encounter some peculiar, almost bizarre cases. But don't be dismayed. The same principles of careful observation and deduction still apply. Every single culprit leaves a telltale clue. Take hemicrania continua, for example. It's this persistent, one-sided headache. Its single defining clue, an absolute, almost magical response to indomethacin. A diagnostic trial is your smoking gun. Or primary cough headache and primary exercise headache. I mean, the names themselves give you the central clue. The trigger is the diagnosis. See? Elementary. Ultimately, the solution to the mystery of headache really lies in careful observation and logical deduction. The clues are always there, hidden in the patient's story, in the character of their pain, and in their response to your interventions. It's our job to see them. Now go forth and solve the case.